Hello, today we will be discussing sarcoidosis. This is a condition that did not get a lot of discussion for me during my training. I added these to my rheumatology lectures when I was teaching sophomore medical students when I found that they didn't have a lot of exposure either. As you listen to this, you will note that there's a lot of features of sarcoid that looks very similar to other rheumatologic diseases that we treat, and thus I wanted them to have knowledge of this as they generated their differential diagnoses. Do note that YouTube has been attaching advertising to my talks. I do not have knowledge of what ads are added. I am not getting reimbursed for these ads in any way, and I do not necessarily endorse the products for which these ads are attached to my lectures. Again, thank you for listening, and I hope you learned something.
Welcome, my friends. Let's begin our journey into sarcoidosis. Basically, sarcoidosis is a multisystem granulomatous disease characterized pathologically by the presence of non-caseating granulomas in involved tissue. Given that the lung is most frequently manifested, it is more often diagnosed and treated by a pulmonologist. However, it is an interest in rheumatology because it frequently has multi-system involvement, including the lungs, the kidneys, the joints, the heart, the skin, the eyes, like diseases such as systemic lupus erythematosus or the vasculitis or seronegative spondyloarthropathies. In addition, rheumatologists are frequently involved in the management because immunosuppressive medicines are used that the rheumatologist has the most experience with. Again, this is just a list of the conditions. It is a multi-system disease. Now, the hallmark of this is the pathologic finding of a non-caseating granuloma. And basically, a granuloma, which is shown in this picture, is sort of a little nodule. It's microscopic. This is a histologic specimen that's surrounded by lymphocytes. These are primarily T helper cells with central macrophages, a body of macrophages. Now, sometimes these macrophages can take the appearance of epithelial cells, so they may be called epithelioid. They can sometimes include giant cells, and there can sometimes be inclusion bodies. Now, as with most of the diseases that we discuss in rheumatology, there's felt to be a genetic basis and then something that kicks it off in the environment. The clues to the genetic basis include primarily population studies where it's found that certain ethnic groups seem to be more involved. For instance, African Americans in the United States have an incidence about 2.4% versus only 0.85% of European Americans. People of Scandinavian, German, and West Indian descent have a much greater incidence than people of Japanese, Spanish, or Portuguese descent. There has been noted to be a familial clustering, and probably the piece of data that most pushes us in this direction is the concordance in monozygotic versus dizygotic twins. With respect to the thing in the environment that kicks it off, certain antigens seem to be associated, such as wood-burning stoves, tree pollen, insecticides, a moldy environment, service in the U.S. Navy, metalworking, firefighting, and there seems to be an increased incidence in the World Trade Center responders. So how do we recognize the disease? Epidemiologically, this tends to occur in people in their middle ages, most often the ages between 20 and 60. We talked about how in the United States, the African American population seems to be much more involved with this condition than the European American population. And in the black population, the disease probably occurs on the average 10 years earlier. There's several presentation types. However, the lung is the most frequent site of presentation. A lot of times it can be incidental. Somebody will have a chest x-ray. They'll be found to have hyaluroadenopathy on the chest x-ray. However, they can also present with lung involvement with shortness of breath, cough, chest pain. This can be seen on chest x-ray. There can be other pulmonary manifestations such as a pneumothorax or pleural thickening, a chylothorax, pulmonary hypertension. This is an example of a chest x-ray. One can see the hilar adenopathy. There can be some specific presentations such as Lofgren syndrome. These patients present with fever, bihilar adenopathy, ankle swelling, and erythema nodosum. There's also a condition called uveoparotid fever or Hertford syndrome. These patients can present with fever, bilateral uveitis, parotitis, and that can be with or without a seventh cranial nerve palsy. The non-pulmonary manifestations, the skin can be involved several ways. There's papillary sarcoidosis, and one can see the skin papules here. This is another example of papillary sarcoidosis around the eye. They can have nodules. One can see how this could be very cosmetically deforming. There can be plaque-like lesions associated with sarcoid. This is lupus pernio, and what you see sort of these heaped up lesions of sarcoid, but in a distribution of the mask of the wolf or lupus. There can be erythema nodosum, which is a paniculitis, a subcutaneous paniculitis, or they can just have subcutaneous sarcoidosis. The eye can be involved. They can have a uveitis, and what you see here is you see these little spots in the anterior chamber of the eye. These are described as mutton fat precipitates. There can be involvement of the conjunctiva, and this doesn't look particularly angry, but there's sort of a heaped up appearance of the conjunctiva in this eye. And then they can have sarcoid in the eye, intraocular sarcoid, or they can have sarcoid in the orbit or extraocular orbital sarcoid. In addition to the lung itself, the upper respiratory tract can be involved with laryngeal sarcoid or nasal or sinus sarcoid. The heart can be involved. They can have muscle involvement, myocardial involvement. It could affect the conduction tracts, causing a heart block or arrhythmias. They can sometimes progress to heart failure, and there can be valvular dysfunction, as one can imagine if one got sarcoid nodules on the valves. We talked about the lymphadenopathy of the lungs, or the hilar adenopathy. They can also have lymphadenopathy in other places, or hepatic or splenic involvement in enlargement. Acute inflammatory mono or polyarthritis can be associated, and one can see how this would then lead this to be part of the differential diagnosis of a rheumatologist. They can have a chronic arthritis with periosteal bone resorption, and this can mimic rheumatoid arthritis, and there can be muscle involvement with granulomatous myositis. They can have involvement of the exocrine glands with painless swelling of the salivary gland, and parotid gland involvement can occur, which can sometimes lead to a cranial nerve 7 or a facial nerve palsy. There can be kidney and electrolyte abnormalities due to extrarenal production of calcitriol by the activated macrophages. This can lead to hypercalcemia, and they can have an interstitial nephritis. Again, one can see lung, joint, skin, kidney. One starts to see how it could fit very much into the differential diagnosis of systemic lupus or some of the vasculitis conditions that we see. Neurologically, they can have central nervous system disease, or they can have focal neurologic disorders. There can be seizures, there can be hypopituitarism, headaches, and they can have a granulomatous meningitis. The endocrine gland, we talked about hypopituitary. This is involvement at the brain level, but they can also develop a goiter. The stomach can be involved, or the gastrointestinal tract can be involved. When that's involved, the stomach is most commonly involved. And lastly, the bone marrow can be involved. Up to 10% of bone marrow samples demonstrate granulomas. The patients can have an associated anemia, either iron deficiency or anemia of chronic disease, with or without bone marrow involvement. And they can have a leukopenia or a low white blood cell count, or a thrombocytopenia or a low platelet count. And again, this can occur either due to the bone marrow involvement or the splenic involvement with compartmentalization or trapping of the white blood cells. There can also be systemic symptoms such as fever, which is usually low grade. They can have a weight loss, perhaps up to 10% loss in up to 30% of patients. Fatigue is very common, occurring in up to 80% of patients, and they can have palpable peripheral lymph nodes in 10 to 15% of patients. Just as a reminder, this is a nice little picture sort of outlining some of the problems that can occur with sarcoid, including neuropsychoid, eye involvement, the skin involvement, including lupus pernio, hilar adenopathy, granulomas, hepatomegaly, splenomegaly, erythema nodosum, and this is just a little picture to remind us of the hilar adenopathy. So how is the diagnosis made? Typically, non-caseating granulomas are demonstrated on biopsy in the appropriate clinical setting. And we talked about what those non-caseating granulomas look like on histologic specimen. Therefore, tissue biopsy is very important. The most common target site is the lymph nodes. However, incidentally, it can be found in other places, such as the skin, etc. In a position paper in the American Thoracic Society Journal by Krauser, it was suggested that patients with a Lofgren syndrome, such as fever, hilar adenopathy, edema and erythema nodosum, or Hereford syndrome, which includes, or the UV parotid fever, which includes bilateral uveitis, parotitis, and fever, and lupus pernio, these patients do not need to have a biopsy. And the other part of the diagnosis is that other causes of granulomatous inflammation need to be excluded, and thus the differential diagnosis is important. And I've listed the differential diagnosis here. The thing that we consider probably most often and firstly is TB, tuberculosis, or endemic fungal infections. And which fungal infection one seeks depends on where the patient lives, where they're involved. For instance, in Indiana, we look for histoplasmosis. One needs to consider hypersensitivity pneumonitis or chronic beryllium disease. Interestingly, certain of the immunotherapies used to treat cancer, which are called immune checkpoint inhibitors, have been shown to have a sarcoid-like picture. Lymphoma, as one could imagine, where one has enlargement of lymph nodes. This can sometimes look like sarcoid and needs to be excluded. The ANCA-associated vasculitis conditions a lot of times can involve the lungs and the kidneys, and they can have a granulomatous vasculitis associated. And common variable immunodeficiency is another thing that can have a picture that looks like sarcoid. So what are the tests we use? What are our special studies? Well, obviously chest x-ray is important because a lot of times this is found incidentally on chest x-ray. And thus there's a staging of the x-ray. Stage 1 is just bilateral hilar adenopathy with no other lung involvement. Stage 2 is hilar adenopathy with reticular opacities in the lungs. On serial exam, stage 3 is reticular opacities with shrinking lymph nodes, and stage 4 is severe lung disease with the opacities, volume loss, conglomerated masses, and marked traction bronchiectasis may be seen. There can be calcification and cavitation or cyst formation. So this is certainly a very damaged or end-stage lung. The lung can be looked at in other ways with a high-resolution CT. We can seek areas of sarcoid involvement with a PET scan or a gallium scan. I think pulmonary function tests are very important in evaluating this to see if there is significant lung involvement or if there is lung involvement other than incidentally on chest x-ray to help guide and determine whether treatment is needed. The angiotensin converting enzyme is frequently cited as being tested in sarcoid, and indeed I must admit I'm guilty of checking for that myself. but it is not very sensitive, only about 75% sensitive, and is not very specific with a 10% false positive rate. So it's used, its benefit is sort of debated. And then probably one of the most important things to be done in making the diagnosis is the biopsy. Peripheral sites, if one presents itself, such as a nodule, or bronchoscopy or surgical mediostenoscopy. So how do I work it up? What do I do? I check chest x-ray, that's given, a blood count, renal function test, including looking at the calcium and liver function, and this can be accomplished by a chemistry profile. I do some tests for tuberculosis, either a PPD skin test or an interferon gamma release assay such as a quantiferin gold or a T-spot. A 24-hour urine calcium is checked. Vitamin D levels are checked. Pulmonary function tests, again, we talk about how that's important in determining, in staging the disease, to determine if treatment's necessary. Immunoglobulins are checked. An EKG can show whether there's a heart block or arrhythmia. May give a clue if there's involvement. Fungal testing, depending on the location, and again, different parts of the world have different fungal elements that could look like sarcoid. And then the biopsy site is considered. The lymph node is the primary site of biopsy. However, I have had the diagnosis made incidentally with tissue biopsy, such as the skin. If there is a hilar adenopathy and tissue sampling is felt to be necessary, endobronchial ultrasound-guided biopsy is what is recommended. And then, of course, an ophthalmology evaluation to see if there's any eye involvement. So how is this treated? Number one, for patients that have an incidental finding, such as a chest x-ray that shows hilar adenopathy, but which further testing, such as for the lungs and other extra pulmonary manifestations, is not remarkable, no treatment may be required. When treatment is initiated, most oftenly it is with the glucocorticoids or the corticosteroids, such as prednisone. Immunosuppressive agents are used. Classically, methotrexate probably has the data most supportive. However, other immunosuppressive drugs are used, such as azathioprine, levoflunomide, mycophenolate, hydroxychloroquine. In my practice, I tend to use azathioprine before I use methotrexate. Methotrexate has, as an associated possible side effect, an interstitial pneumonitis or lung disease, and I don't want to risk that in a patient that I'm concerned about lung disease, so I use azathioprine. The tumor necrosis factor blockers, infliximab and adalimumab, have been shown to be of benefit. If one reads the literature, it is suggested of patients with pulmonary involvement, there's up to a 5% mortality. In my practice, I found that the response and the prognosis of sarcoidosis was very good, although certainly patients with pure pulmonary disease probably did not make it to my office. But in my experience, generally we had good response with corticosteroids and immunosuppressive drugs, and indeed lifelong therapy was not even required. We would get to the point where we could gradually taper and stop the medicines. I hope this is helpful information to you. Thank you for listening to my talk.
Thank you for listening to this discussion about sarcoid today. I next plan to launch into a set of discussions about the vasculitis or arteritis conditions. Again, these are moving slowly. I get to them when I get to them, and I apologize for that. But again, thank you for your interest, and have a very good day.